Good afternoon, everyone. I see we have some attendees still logging in. Hi, my name is Krista Sineski. I am a marketing director with EloQuest Healthcare, and we are so pleased to have you here today for one of our Wednesday workshops, which is a format designed to share expertise from a variety of clinical subject matter experts. This is all with the goal of giving you information and resources to support improved outcomes in your facilities. Today is the second in a three-part series entitled Vascular Access Jamboree, a how-to guide. Our presenter, an expert in infection prevention, Chellie DeVries, will be our presenter today, and the topic we'll be focusing on in today's session is all about collecting data and implementing change, using that data to implement change. So if you missed the first in the series, introduced to this topic, a recording is available to get you caught up. You can access that through our Wednesday workshop event page. So our presenter today, Chellie DeVries, she has been involved in infection prevention and hospital epidemiology for 25 years. If you know her, you know that she's passionate about vascular access devices and devotes her time to education on this topic. She's authored numerous peer-reviewed journal articles and textbook chapters. She was a reviewer in the 2016 as well as the 2021 Infusion Therapy Standards of Practice. She's an adjunct research fellow with Avatar, the Alliance for Vascular Access Teaching and Research. And she also serves the Association for Vascular Access, both nationally on the board of directors and locally serving as the co-president of her local network. And she brings all of this experience to the many stages and virtual platforms that she speaks on. And we're so grateful to have her here with us today. So please join me in welcoming our Wednesday workshop presenter, Chellie DeVries.
Thanks, Krista. Thank you so much. It is so exciting to be back and having this conversation, bringing us to now step 2 of our Vascular Access Jamboree how-to guide. And we're going to talk about the data we collected and how we use it to implement change. I do always need to add the disclosure that as a member of the board of directors with the Association for Vascular Access, the views I share today are mine alone and do not represent those of AVA unless explicitly stated. So with that, I want to start with a polling question. So we met for the first time 2 weeks ago and started talking about the Vascular Access Jamboree a bit. So for those of you who were able to join last time, have you approached your organization about trying to do something like a Jamboree? Your options are yes, no, and no, but I am going to. All right, well, that's pretty fantastic. About half of you either have said yes or no, but I'm going to. So very, very cool. I can't wait to get feedback on how it goes as more places start giving it a try. So, all right, then moving on. So I'm going to go with a now what. You've reviewed the information that we first talked about. You've identified who your team members should be to get you started in your organization, and you have a date on your calendar for your first Vascular Access Jamboree. So now I'm going to share how our journey went a little bit and how we got where we are. So our original story, and we've presented and we've actually published this, but we were doing our infection control annual report. We realized that when we looked retrospectively at our bloodstream infections, both CLABSI and peripheral IV, 25% of those had documentation in the chart that the dressing had either been reinforced or prematurely changed. At that same time, we were doing individual point prevalence rounds with our dressing manufacturer originally. And time after time, we were finding about 55% of our peripheral IV dressings were reinforced, lifted, or completely disrupted. 15% of those had the insertion site exposed. We went through the literature at that time. We looked at the infusion therapy standards of practice, and we knew that dressings had to be a priority. There was an associated risk of bloodstream infection in the literature, and there was a temporal association, which doesn't necessarily equal causation, but we had reason to believe that this is something that could help us improve our outcomes. So we undertook a quality improvement project to decrease the number of premature dressing changes that were due to disruption. As always, we gathered everyone who we thought may have a role. So we had vascular access, infection prevention, nursing education, our nursing, clinical nurse specialists, materials management, and we actually had our WOCN, our wound nurses, with us too. We looked at several products and strategies to try to identify what was going to happen, and we defined our goal in advance. What we always ask ourselves here is, how will we know we've won? So as we're trying to do quality improvement, we needed a benchmark that we were striving for, and we identified it would be 80% of dressings remaining fully intact, and we defined fully intact as all four corners down without reinforcement for up to 7 days, or when the dressing needed to be changed for other reasons. As we launched this, we found education alone was not enough to achieve our desired outcome. We tried to just switch dressings, and that also did not help us get to our goal of at least 80% dressing staying adherent. So at that point, we began combining dressings with the gum mastic liquid adhesive, and both of those dressings used in conjunction with the gum mastic got us to greater than 85% fully intact dressings during the time of our pilot. Originally, we looked at about 200 patients receiving that dressing in combination with the adhesive, and we had no skin injuries reported in that group. The data itself, sorry, a little bit of technical, okay, whoops. Sorry. So our pilot study is what then fueled our ongoing gathering and what became our Vascular Access Jamboree. And so we talked last time about the need to have a data dictionary or define in advance what it is you're going to look at. So using this as an example, how do you define intact? We chose to define it for the purpose of our quality improvement study as all four corners down without reinforcement. The standards of practice now do help define that more clearly, but originally at the time we were doing our work, there wasn't that guidance out there, and we realized as we began to gather our data, we needed to make sure we were all going to record information consistently. Ask the question as you go out and round with your Jamboree, according to your organizational policies and expectations, when is it okay to reinforce? For us, we have become a thou shalt not reinforce hospital by policy. We do still see reinforcement occur at times, and we're continuing to gather data to try to understand the why behind that, and then identifying with your team and your organization, is it okay for the edges of the dressing to be lifted or rolling up? And you'll see the standards again have taken some pretty strong language around that. So why is this one of the elements that we think is crucial to include? I shared our original experience when we looked at 25% of our infections having that temporal association, but it was a study that was done by TIMS that actually looked at the risk of catheter-related infection and bloodstream infection increasing more than threefold after 2 dressing disruptions. So it wasn't just a concept. The standards told us that dressings needed to be changed immediately if they were non-intact. The research done by TIMS that showed us that if we repeatedly change those dressings, we were going to potentially increase our patient's risk of infection by more than threefold. And then we looked internally at our data and we saw that temporal association. So this became an institutional priority for us. When you look at the current, the 2021 infusion therapy standards of practice, the quality improvement standard is actually one of my favorites. And so we're not supposed to have favorites, but quality improvement is what is going to continue to drive our outcomes and our processes to improve what's going on in the facility. So the quality improvement standard states that we have activities implemented to advance safety and excellence in infusion administration and bad insertion and management. In vascular access, we have spent a tremendous amount of time focusing on the insertion, and we need to make sure that we're including the care and maintenance as well. And so very specific, the quality programs incorporate surveillance, aggregation, analysis, and reporting of those indicators and adverse events, and that we take action as needed to improve the practice, the processes, and or the systems. So it's very clear that there needs to be ongoing data collection and that we need to do something with it. Keeping a line list is not enough. We need to aggregate and analyze and actually feed that data back. As we move into the actual elements of that standard, I've highlighted a few key points, but there is so much information in the standard that can help us do what is necessary to improve things for our patients. I highlight A because it's making sure we have a just culture, but recognizing that we also need individual accountability with a focus on improving those systems and processes by clinicians and leaders. And I think this is so important to us as individual clinicians, as vascular access experts, as infection preventionists. Each of us needs to have that individual accountability. And this is not just a leadership function. This is at the individual level as well. The next one I highlighted is making sure we're actually going out to assess current gaps in practice and identify, minimize, or eliminate those barriers to change and improvement. And I think it's very interesting because it actually calls out that those barriers could in fact include attitudes as well as time and financial and physical resources. And we do need to take that into consideration. And as we build our approach, make sure it is part of the discussion, making sure we're using systematic methods and tools to guide our activities, the use of audit and feedback when we're implementing change in practice, and then the encouragement to make sure we're sharing our improvements gained through those processes internally, but also externally. So this builds us up and it helps contribute to the actual changes. It should not just be an element in bean counting. So what we learned during our original rounds together and what became our Jamboree is that our opportunities for improvement are often in an interface. So an individual product is supported by a number of products that go along with it. And if we look at the topic of dressings, we have our actual dressing and we have our CHG sponge that we use underneath our dressing. But dressing disruption can also be driven by site selection. So we have our peripheral IV and our central line manufacturers here working with us so that we can optimize site selection, so that we can optimally place our CHG sponges, so that we can optimally place our dressing. And then for us, the addition of gum mastic to then help it stay together. But each of those individuals join us as we do our vascular access Jamboree because we can then leverage the expertise among each of those to help us get the outcomes that we desperately want and that our patients deserve, which is going to be a vascular access complication-free hospitalization. That's our goal. And this is always done direct observation rather than chart review. Policies are great, but we want to review the actual practice. We want to have the opportunity to talk to the bedside staff so they can share with us what their experiences are, what their barriers are in achieving that successful dwell, if that's what's at stake. And they can give us feedback individually as well as in aggregate about how the products work together or how they're not working together for them. They can help suggest to us what we need to do as leadership in the organization to help make that difference. And that is really where the power, we believe, of our Jamboree is, because it's this interface, absolutely, of multiple different products working together in concert to help drive our outcomes. And having that expertise from each different group, along with our internal expertise, has been an incredibly powerful experience for us. So I am a Hamilton fan. And so if we finish our rounding, the question is what needs to happen? So we review the preliminary data, or if we've used the apps, we have instant access to that analysis. What needs to happen based on what we observed today in our vascular access Jamboree? And we actually did have our Jamboree this week, but how do we work together? Is this going to be an individual project that needs to happen, or is it something that maybe 2 or 3 of our vendors are going to work along with our clinical education to make that difference? Do we need resources? Is there something we need to bring in and provide to allow us to get the improvements we're striving for? Then is there someone else who should be invited? After we've gone around and done those rounds, is there someone missing? Is there someone that wasn't invited, wasn't included, that could add value to what we're doing and help us reach that next level with our outcomes? So one more poll question. Do you agree that working collaboratively with our bedside staff, leadership, clinical leaders from the hospital and industry together can help tackle some of the difficult problems we're currently facing in vascular access? Yes, no, or yes, I agree, but my organization will not allow it. Wow, that is a resounding yes. And I'm sorry to see the 2% of you that your organization won't allow it. I really encourage for that. If you look at the infusion therapy standards of practice, one of the standards is actually on product evaluation. So it is within that standard, not specifically in the quality improvement standard, but in that standard, when they talk about product evaluation, they say we need to provide education and training for the use of products selected for evaluation. And within that, they state we should consider, I'm reading this, so I am going a little bit sideways on my view here, but consider support and involvement by the manufacturer in product evaluation. So it is something to bring forward if you're getting that block from allowing industry in. The standards of practice do support our involvement with industry for evaluating the products in use. If that's helpful to you, I just wanted to pull it out if that's something that you haven't considered bringing forward. Industry partners can help support our efforts. Krista mentioned that they are going to share the vascular access audit tool that they developed to help assess both dressing integrity as a point prevalence as well as skin condition and moisture. If you need a tool to get started and you don't have something that you're using, it's really a great way to take a look. You can download it. It's in the handouts that are posted in the control panel. But just a really nice way if you want to get started, and this is a topic that's of interest to you, it can help you with that systematic observation and build in how you're going to define each of these terms so that you get consistency in your evaluation. So a great place to start and a really nice tool to go ahead and get started. So again, these are super short snippets as we share how we have collected data, how we have used our Jamboree, and next time we're going to get together, we're going to talk about the post-implementation monitoring. So we did our pilot study, we did an implementation, we continue to monitor with our Jamboree, and how does that continue following implementation to gather robust data and to continue to refine the practices that we have in place to try to improve our vascular access outcomes, because it is an iterative process and we always have room for growth. So with that, Krista, I think we have time for questions.
Yes, thank you so much. Thank you. Again, like you said, we're trying to get as much information in there as briefly as possible, but we are now to our Q&A portion. We do have a few questions that have been submitted, and continue to type any additional questions that our audience member has, and we'll address as many as we have in the brief time that we have allotted. So Chellie, are you ready for your first question?
I sure hope so. Let's see, where are we going?
All right, so let's see. Okay, what do you think is the biggest challenge about allowing industry to the bedside like you do for this?
You know, that's a good question. For us, I think it's gaining the trust that this is not a sales pitch. And I think I talked last in our original session, we set ground rules on what is and is not allowed for behavior. So there's no selling to staff, there's no upselling, there's no discussion about trying to bring in a new product that the hospital has not already selected to use. We can have that conversation as part of our debrief, but building the trust as we bring this group around that this is not a sales pitch, it is not a sales opportunity, it is a quality improvement activity. And we've had excellent compliance among everyone who has been involved with us in that regard. And also, I think I touched on this a little bit when we were looking at those poll questions, the belief that we shouldn't have industry at the bedside using the current infusion therapy standards of practice, looking at that language in that product evaluation standard, which again says consider support or involvement by the manufacturer specific to product evaluation. But product evaluation is also part of quality improvement as we continue to see how the products that we have implemented are working. So I would use those two in conjunction, but building that trust, and you have the relationships with the clinicians, with our vendors. And also, we're very lucky in vascular access that so many of our industry partners are actually VABC, they're CRNI, and for the non-clinical partners, many of them have their vascular access industry partner certification. So we're bringing additional value to the organization, and many times we're bringing absolute experts in the field to help us out.
Great, thank you, thank you. Okay, so how do you suggest gaining consensus if it doesn't naturally exist?
Data dictionary, so critical. You could call it what you want, but defining in advance how things are going to be evaluated. What does good look like? What does intact look like? What is lifted? What should tubing look like as far as dating? What's your policy? So that should be defined in advance, and it really should minimize that question. For me, we always have an RN from our facility who is ultimately the one who is going to record and be accountable to those observations. And if there is any disagreement, we have that conversation. I won't say before we leave the bedside, because that's not a conversation to have at the patient's bedside, but before we leave the unit, if someone shares that they had a finding that's very, very much not in alignment with the other observers, we'll go back in and take a look, or we are able to capture photos as part of our rounding because it's built into our HIPAA compliant reporting system, and we'll pull back up a picture and take a look. We were actually just doing that earlier this week. So define in advance, hold yourself to those definitions, and if you need to modify your definition, do so, but do it comprehensively. And we always have, I say always, and actually it has been always, but always a nurse from the organization represented who will be ultimately the decision maker, but then getting that consistency, documenting if there's a question, and you can bring it back to that full group for further discussion.
Okay, great. I guess one more question about your dressing practices. Regarding reinforcement, the dressing can be reinforced with sterile tape, like window painting is the term that's used at the time of dressing placement. Can you speak to this practice?
So I can share my opinion on that and why we made the decisions we made. So we made up a term, and it's not okay to make up terms. I consider that pre-enforcement, like we're fixing to get ready for a dressing to fail, so we're taping it back down. So we discourage it, and part of that is it really ought not to be serving a purpose. And there was one study that came out that actually looked at a series of dressings, and when they reinforced, or in their case, pre-enforced and window pane that dressing, the dwell time did not actually increase. It was one relatively small study. I think that was Richardson. I'm sorry, I'm talking very impromptu in this response, but they did not see an improvement with that, which to me would further suggest not to do it. You're not increasing your risk of infection by pre-enforcing or window painting a dressing. But when it comes to a quality audit, it is truly impossible to tell when you see that extra tape on the dressing, is it something that was pre-enforced, or was it something that was taped back down because the dressing failed? And that's also from the understanding what's going on at the bedside. It's very difficult to make that assessment after it's been applied when you go back and you look at the dressing. So also nothing in the standards that supports reinforcement, either in the CDC guidelines or the INS standards. There's nothing there to support that use of reinforcement. I hope that's helpful. I'm not, again, that's how we've chosen to approach it here. And yeah, honestly, once we added the gum mastic, so we were coming from a point where, as I shared, only 55% of our dressings were fully intact. So it's taken us a number of years to truly gain the confidence of the staff, who previously they were faced with many more frequent dressing changes. And it was an honest attempt to try to prevent that from happening. With the improvements we've seen and sustained now for a number of years, I think we're going to see that less and less.
Awesome. Yeah, that's great. Thank you. Okay, so the next question is, do you need an IRB approval to do this? I assume that's related to your rounding practices.
Okay, so for us, this was a quality improvement project, and it is an ongoing quality improvement effort in the organization. So we don't need, and nobody needs IRB for a quality improvement project. Always check with your own organization. If you are collecting data for the purpose of research, IRB definitely needs to be involved. But if it's quality improvement, this is about making a change immediately in patient care as a result of direct observations. That is not something that is under the purview of IRB. Always check with your own organizations, particularly if you're collecting data and you're thinking about doing it as a study. If you're doing it as a study, if you're doing it as research, IRB will generally need to be involved. But if it is about changing practice at the bedside right now, that is not an IRB indication.
Okay, perfect.
Always check with your own institutional policies.
Always a good security there. Okay, so the next question I have for you is, with regard to a product evaluation, knowing a specific product is far superior than another, however, the facility does not have the budget to institute or implement, does this pose an ethical dilemma?
Ooh, I'm honestly not sure the best way to answer that. Understanding that you need to define in advance what you're trying to achieve. So when you say there's something that is clearly better, it's having a plan for quality improvement to address the problems or the opportunities that you're facing in your organization, finding a way to do that in a financially responsible way is something all of our organizations are faced with. So working within the constraints that you have available to you is the reality of healthcare. So I think that's the best I can do with that. I'm sorry.
No, that's perfect. And I think also just understanding that there could be, some cost, the way cost is measured, variance, like maybe you're spending more on this product, but you avoid costs related to other health
Absolutely.
complications and things like that that could be compared as well. Okay. I think we have time for just one more question.
Okay.
So how do you balance changing a dressing that has prematurely lifted around the edges, at the edges level, I guess, and changing a dressing too frequently?
So the current standards of practice do define that as any portion of the dressing that is lifted around the border or the transparent portion does fall under the standards stating that a dressing change should be done. We organizationally do those as a monitor. We have not yet fully implemented that at the earliest lifting of an edge, a dressing be changed. That is what the current standards are suggesting, but ensuring too that your staff who are performing your dressing changes are actually competent in the dressing change. In the TIMSIT study, it doesn't tell us the why behind those increase in infections, and there's a number of things that could contribute to that. I do believe in part it could be technique. So as you go to compliance with the standards and immediately is the language that's in there, changing those dressings as defined by your organization and within the standards, ensuring that you're not going to introduce unnecessary risk by kind of what you mentioned, excessive or premature dressing changes. Ensure that your staff who are tasked with those dressing changes are competent, but define in your policy what you're going to consider a non-intact dressing. Look at the standards of practice, certainly, see the language that's in there, see the references that were used to determine that, and evaluate those levels of evidence to make the decision that is that balance and best for your patients and your organization.
Thank you so much for that reply, Chellie. Well, we are at our time limit. So this concludes, I guess, our Wednesday workshop presentation. Thank you so much, Chellie, for your time and attention today. On behalf of all of Aliquest Healthcare, I want to thank our audience for attending this. As we said, this will be recorded. If you'd like to share with your colleagues and friends, please feel free to pass along that link. And again, please feel free to join us for our third and final presentation in this series, Post-Implementation Monitoring, as Chellie mentioned, which will occur in 2 weeks on Wednesday, August 11th. Again, thank you everyone for being here today, and we hope to see you in 2 weeks.
Thank you. Bye-bye.